Imagine you have two cancer patients right in front of you. Patient 1 is 61 years old, fairly thin, with a really low intermuscular fat volume. Like, specifically, the data says 100.6 cubic millimeters.
Right, so practically no fat marbled into the muscle.
Exactly. And then you have patient 2, who is almost 70 and has double that amount of muscle fat. High IMFV, sitting at 201.4 cubic millimeters. Both have non-small cell lung cancer. Both are getting the exact same immune checkpoint inhibitor therapy.
And, conventional medical logic tells us patient 1 should have the edge. Younger, visibly leaner.
Right, but the data shows we've had it completely backwards. Patient 2, despite being a decade older and having way more muscle fat, actually has a far better immune profile to fight off the cancer. Okay, let's unpack this. Welcome to today's Deep Dive. I'm your host, and with me is our resident oncology and data expert.
Hey, glad to be here. Yeah, our mission today is really to decode this groundbreaking 2026 multicenter study from Nature Partner Journals. We're looking at a massive data set, 2,132 patients across 8 cohorts.
It's huge.
It is. And the goal is to comprehensively break down how researchers are using AI to map multidimensional body composition and how that predicts immunotherapy outcomes. It reveals some truly shocking gender differences.
It really does. But before we get into the AI, we need to talk about why patient 2 survived, because this points to the obesity paradox, right?
Yeah, exactly. It's this deeply counterintuitive phenomenon in oncology. Sometimes a higher body mass index, or BMI, actually correlates with better cancer survival, especially with immunotherapy. But traditional BMI is fundamentally flawed.
Because it's basically like judging a book by its page count.
Yes.
I mean, if I have 2 patients with a BMI of 25, how drastically can their internal tissue distribution differ? The BMI tells you the mass, but not the plot.
It could differ wildly. One might have fat packed deep around their organs, and the other stores it all just beneath the skin. BMI completely fails to capture the multidimensional nature of body tissues.
So we need to look closer. Non-small cell lung cancer is tough. And these immune checkpoint inhibitors, or ICIs, they work by taking the brakes off the immune system.
Right. They unmask the tumor so the patient's own immune system can attack it. But taking the brakes off only works if the car has gas. The drug's success depends heavily on the patient's bodily environment.
Which brings us to the tech. How do we actually measure that environment accurately without, cutting someone open?
That's where the AI pipeline comes in. The researchers use a deep learning-based auto-segmentation system called InUNet.
InUNet?
Yeah. Instead of human manually tracing tissues on a CT scan, this AI automatically extracts 92 multidimensional parameters from baseline CT scans.
Wait, 92? What is it actually measuring?
Well, it measures 2D areas, tissue densities, and full 3D volume spanning all the way from the 8th thoracic vertebra, so T8.
Like mid-chest.
Exactly. From T8 down to the 3rd lumbar vertebra, L3, in the lower back.
Okay, to help keep all these tissues straight, I like to use a mnemonic for the 4 key types the AI looks at. SIVS, SIVS, subcutaneous, intermuscular, visceral, and skeletal.
That's a great way to remember it. And we have to highlight the evidence grading here. We are talking about 1,919 patients in just the prognostic cohorts.
Wow.
And when they tested the AI against manual measurements from an expert radiologist, the intra-class correlation coefficient, the ICC, was greater than 0.87.
Meaning it was incredibly accurate.
Highly accurate, and it increased efficiency by 100-fold. It does in seconds what takes humans hours.
Okay, let's do a quick recap before we move on. Bullet 1, BMI is way too simple, so this AI extracts 92 precise parameters from CT scans. Bullet 2, this deep learning AI is highly accurate with an ICC over 0.87 and 100 times faster than a human. Bullet 3, it measures fat and muscle all the way from T8 down to L3. So for you listening right now, think about your own body composition. If an AI scanned you right now, do you think your muscle or your hidden fat would be the loudest voice talking to your immune system? Because, well, the answer entirely depends on your gender.
It really does. Looking at the demographics, the clinical cohort was 84.8% male and 15.2% female. And right at baseline, males naturally had higher skeletal muscle volume and vertebral body volume, while females had higher subcutaneous fat.
The fat under the skin.
Right. But interestingly, there was no baseline difference in intermuscular fat.
The fat marbled inside the muscle. But how that fat behaves during cancer is totally different. Let's look at the men first. The data says IMFV, that intermuscular fat, is king.
It is. For males, higher intermuscular fat volume and area are strong independent predictors of better overall survival.
And they found exact mathematical cutoffs, right?
Yeah, the AI pinpointed the exact cutoff to maximize survival difference. An IMFE index of 0.196 and a T8 vertebral body volume cutoff of 32.3.
So if a guy has an IMFE above 0.196, his chances are way better. But for women, it's completely inverted.
Exactly. For females, the dense fat is the enemy. Lower T12 subcutaneous fat density was linked to improved survival. Same with lower intramuscular fat density at the T9, T10, and T12 levels.
Okay, hold on. Why did just T12 or T9, why does the specific location matter?
What's fascinating here is that the biological relevance of fat is inherently tied to specific anatomical locations. A single slice at L3, which used to be the old gold standard, totally misses the full picture.
Give me an example of that.
Well, in males, the subcutaneous fat area T11 mattered a lot for prognosis, but other thoracic levels didn't. Or take visceral fat density at L1.
Deep belly fat.
Right. At L1, that fat was protective in males, but a major risk factor in females.
Here's where it gets really interesting. Fat inside the muscle helps men survive, but dense fat under the skin hurts women's chances. It's like they're completely different organs.
They practically act like it, yes.
Okay, I have another mnemonic to help us track this. MIFS, MIFS. Males benefit from intermuscular fat. Females benefit from lower subcutaneous fat density.
I like that, MIFS. It captures the gender divide perfectly.
Time for another quick recap. Bullet 1, male survival heavily benefits from high intermuscular fat, specifically an index over 0.196. Bullet 2, female survival benefits from lower subcutaneous fat density, especially down at that T12 level. Bullet 3, location matters. Fat at T11 acts completely differently than fat at L3.
Perfect summary.
So to you listening, why do you think the exact same type of fat behaves like a literal shield in men, but a completely different type of fat dictates survival in women?
To answer that, we really have to zoom in. We're moving from macro-level CT scans down to the cellular battlefield. The researchers used transcriptomic data to figure out why this happens.
RNA sequencing, right?
Yes. They had 190 bulk RNA-seq patients and 23 single-cell RNA-seq patients.
So what is the male mechanism? What is that muscle fat actually doing for the men?
It acts like an immune battery. Males with high IMFV actually have lower exhaustion scores in their CD8 plus T cells and natural killer cells.
Okay, T cells are the assassins, but what do you mean by exhaustion scores?
When immune cells fight a tumor, they use massive amounts of energy. Eventually, they get metabolically exhausted and just stop fighting. But in men with high IMFV, there is a significant upregulation of the interferon alpha-beta signaling pathway and the oxidative phosphorylation pathway.
Oxidative phosphorylation. So they are burning fuel with oxygen.
Exactly. Antigen presentation in dendritic cells is also upregulated. Basically, the fat is an active endocrine organ. It secretes free fatty acids that fuel the T cells through oxidative phosphorylation.
Oh, wow. So it's literally a local snack station or like a battery pack. The fat feeds the T cells so they don't get tired while fighting the tumor.
That's exactly what's happening. And because the immune system is so energized, it forces the tumor to react. High IMFA positively correlates with CD274 expression.
Which is PD-L1, the target for the immunotherapy drugs.
Right. The tumors secrete interferon gamma, inducing PD-L1, which creates this highly immune active state. It's the perfect setup for ICIs to come in and do their job.
That is amazing for the guys. But what about the women? Because we established that high IMFE isn't great for them.
Yeah, the single-cell data show that high IMFE in females actually increases T-cell exhaustion. It's the exact opposite of the men.
Wait, really? The exact opposite?
Yes. But females with high IMFE, and especially those with high T12 subcutaneous fat density, showed differences in their macrophages.
The cleanup crew cells.
Right. They had higher M1 macrophage scores and lower M2 scores.
And remind us, what is the difference between M1 and M2?
M1 macrophages are pro-inflammatory and anti-tumor. They're the good guys. M2 macrophages are tissue repairing, which in the context of cancer makes them pro-tumor. They help the cancer grow.
So the fat distribution in females basically drives the immune system toward the aggressive M1 phenotype?
Yes. If we connect this to the bigger picture, this totally challenges the traditional view that all fat directly promotes cancer progression. It's highly targeted and gender-specific.
Okay, let's lock this in with a recap. Bullet 1, in males, intermuscular fat fuels CD8 plus T cells and NK cells via oxidative phosphorylation, keeping them from getting exhausted. Bullet 2, this creates a highly active immune state with high PD-L1 expression, which is perfect for ICI therapy. Bullet 3, in females, specific fat profiles promote M1 anti-tumor macrophages over the pro-tumor M2 macrophages.
Excellent.
So, question for the audience. If tumor cells and immune cells are fighting a war and intermuscular fat is the supply line, how does that change your perspective on weight loss during cancer treatment? It makes you rethink losing muscle mass, doesn't it?
It absolutely does. Preserving that specific fat is critical.
Okay, so how do we use this tomorrow? What is the clinical translation of this AI atlas?
Well, multidimensional body composition can serve as a non-invasive biomarker. Before a patient even starts therapy, we can run their standard CT scan through this AI for pre-ICI risk stratification.
We'd know exactly how their immune system is fueled before giving them a single drop of medication, but we need to be rigorous here. What are the limitations of the study?
There are a few key scientific caveats. First, it's a predominantly retrospective design, which always introduces some selection bias.
Looking back at all data.
Right. Second, the female cohort was small, only 15.2%. So the female findings, while fascinating, are technically exploratory and need larger validation.
Fair enough. And what about the cellular pathways?
The relationships found in the RNA sequencing are correlational, not necessarily causal. High fat and high energy exist together, but we need to prove one causes the other.
So where do we go from here?
The paper suggests multi-center prospective cohorts to monitor dynamic body composition changes in real time. And even more exciting, interventional trials combining exercise and nutrition with immunotherapy.
This raises an important question, though. How can we actively manipulate a patient's body composition before therapy?
That's the frontier, prescribing specific exercises to build intermuscular fat to optimize that microenvironment.
So what does this all mean? Let's recap this final section. Bullet 1. AI body mapping could become a standard, non-invasive biomarker for predicting if immunotherapy will work. Bullet 2, the limitations include a retrospective design and a smaller female sample size. Bullet 3, future treatments might actually prescribe specific diets or exercises to build muscle fat to boost the drugs.
You nailed it.
So I have to ask you listening, would you be willing to undergo a targeted nutrition and exercise regimen designed specifically by an AI reading your muscle fat, just to make your immune system respond better to a drug?
I think a lot of people would, given the survival benefit.
I know I would. We've gone from macro-level 3D CT scans spanning the chest and abdomen all the way down into the single-cell transcriptomic battlefield today.
It's a complete paradigm shift in oncology.
It really is. But before we wrap up this deep dive, I want to leave you with a final provocative thought. We've always thought of the immune system and our body fat as completely separate systems, right? Or at best, that fat is just this inactive storage unit we try to lose at the gym.
Yeah, that's the standard view.
But if the specific location of fat acts as an endocrine organ, directly dictating whether your T cells have the energy to fight cancer, could the future of oncology involve precisely injecting lab-grown good fats directly into specific muscle groups right before administering immunotherapy?
Wow. Literally installing a biological battery pack.
Exactly. Installing a battery pack right before the fight of your life. I want you to ponder that invisible metabolic war happening inside our bodies every single day. Thank you for joining us on this deep dive, and we'll see you next time.